Thanks, Dan, for that introduction. And last night I saw Dan, and he said, "Oh, that mustache is getting bigger." I had a mustache when I deployed to Iraq, and for some reason, it's come back just very recently. I guess also bigger and less with the regulations of the military. So, thanks for the opportunity to present today. I'm going to present on something a little. It's certainly my passions. And you can see the title here, but really I want to talk a little bit about clinical trials, some of the latest things that we're doing in clinical trials, what I think it takes to train surgeon scientists and particularly surgeon clinical researchers, which is a real problem, I think. And then something a little bit we'll touch on at the very end, which I call the third horizon, which is basically problems I have no idea how we're going to solve. And hopefully we can inspire somebody here to figure that out. These are my disclosures, and certainly I need to acknowledge my my teammates, my colleagues at Shock, and all the people in the TRU and the place that make this hospital so great to work at. So I'll start with this picture here of a case. This is a tractor trailer that ran into another parked tractor trailer on the highway, and I was flown to the scene for. And, bilateral open tibias, I think, are a pretty bad problem, but I think we'll get there. I think we will decrease the reoperation rate, the infection rate, and I think we have sort of the technology and the methods to answer that problem. But the open bimal in an IV drug user, homeless individual that, is kind of gone for a while, then shows up with a horribly infected wound and then disappears again, and then may need an amputation and worsens their social situation and their homelessness, et cetera. I think that's a wicked problem. And wicked problems, sort of by definition, can't easily be solved, or perhaps will never be solved. And I think at some point, we're going to have to start trying to address some of these problems. So the objectives I have for you today, or at least for me to deliver to you today, is to talk a little bit about some of the recent advances in orthopedic trials. They're becoming almost ubiquitous, but we're also, I think, getting better at them. And so I want to tell you a little bit about why I think we're getting better at them. I want to, as I mentioned, identify some of the current barriers to the growth of our surgeon-led clinical research, and then talk a little bit about how we may be able to apply some novel collaborations to really try and address some of these most challenging problems. So when I think about my most challenging dilemmas, these are the things that I'm talking about, right? Like, I want to improve fracture care. Certainly hip fractures, we may not be any better off there. Mobility and mortality after hip fracture still remains extremely high. Open fractures, type 3As and things like that, still well over 10% infection, 15% reoperation. That's not even the contaminated ones. There's, in my opinion, very little training and support mechanisms for surgeon trialists. And ultimately, I think we should be leading research for our field. And then again, how do we address those wicked problems with no solutions? So I think this summarizes my surgeon scientist path. That was me at Gonzaga. I worked in a research lab my first summer, and I've basically done research ever since. That's me and Mo Bhandari and Aresh Sepahari, one of my mentees, riding scooters when he was a visiting professor in Baltimore. And then last year, I had the opportunity of presenting the APREP results, which was my first large trial published in the Lancet. So when I look back at sort of how I've gotten here, I feel like there was an emerging culture, at least when I was sort of growing up in my early surgeon researcher days. And I just picked this 10-year time point. This is when I started residency. And I think at that point, evidence-based medicine was a pretty common language being taught in medical school. The clinical trials in orthopedic fracture care were starting to occur regularly. And these trial groups were being established. So for some of you might know the COTS group, or the Canadian Orthopedic Trauma Society, they published the clavicle trial, McKee's clavicle trial, and a bunch of other important clinical trials. CEO was Mo Bhandari's group that was starting to do large clinical trials, and then Metric was starting to be formed up in the US. And Mo has been a huge mentor for me. And because, again, as I was coming through this 10-year period of both being a resident and fellow and early career person, I was just sort of blown away by the success that he was having, but more just the fact that nobody thought you could do these trials. But when Sprint was published, which was a trial of tibia fractures of 1,100 patients, the trial may not have really changed practice that much, but the fact that they did an 1,100 patient fracture trial was, earth shattering at the time. And then 3,000, 1,200, 1,500. He was just doing trials at a level that nobody could achieve. And he was going around giving a grand rounds talk called, Think Big. And so when I think about that, for those of you that aren't big cricket fans, this is Test cricket, which is sort of the gold standard of cricket. It's also 5 days and pretty boring. But I really wanted to see if I can emulate some of those trials, ideas where the common clinical problems, simple interventions done on a large scale. But I also wanted to see if maybe I could innovate a little bit too. Maybe we could do things a little bit differently. And so I think anytime I say me or I'm really talking about me and all my collaborators and my mentors and people that have shared this vision with me. So Sheila Sprague and Nathan O'Hara, who are in the gala type picture and at the top of the right side of the screen, they're my closest collaborators. Sheila's at McMaster and Nathan's at Maryland with me. But O'Toole, Bandari, Fabani, Devereaux, these are all like huge trialists in cardiology and other fields. And then on the bottom, Leah Gatton, Lucas Martian, Joe Patterson, these are all, essentially mentees of mine, people in the first 5 years of practice who are up to really good things and hopefully will be the next generation of surgeon trialists. So since I started at Shock, I went, after I finished my fellowship, I went back to Vancouver, practiced for a couple of years, and ultimately came back to shock trauma because I wanted, really high clinical volume. I wanted to be in a really collaborative environment that Dan kind of mentioned about. And I wanted the opportunities to balance, high volume clinical with the ability to do big research. And so since 2015, when I've been back there, I've really focused on these two missions, which is trying to conduct large, rigorous clinical trials and then try and mentor and train other people to do the same. And so I think I've contributed to at least 15 plus trials, most of them multi-center, probably closer to 20 or 25. And I think what I'd like to do is spend about 20 minutes talking about these specific trials and the actual innovation within the clinical trial design. So we'll talk obviously about the clinical problem, but also a little bit about the innovation that went in. So the PREP-IT program is a program of 2 trials that includes APREP and another study that I'll talk about. And then Prevent Clot was Bob O'Toole's study that I was heavily involved in study design. So we'll talk about these different study designs for the next 20 minutes or so. So aqueous PrEP, as I mentioned, this was published in the Lancet in October. It was simultaneously published at the OTA. For me, certainly my most proud research moment. To have anything orthopedic published in the Lancet or New England is a huge deal, at least in my opinion. And so this study sought to determine what skin prep you should use for open fractures, right? These are aqueous solutions only, so betadine or Hibiclens or whatever. So it's not ChloraPrep or DuraPrep. And the rationale is in open fractures, some people believe you shouldn't put alcohol in an open. So that was the rationale for it. Our primary outcome was surgical site infection, as you can imagine, and reoperation. And there was a lot of data out there suggesting that chlorhexidine is better, but betadine has been sort of the gold standard, particularly for openings for a really long time, at least in my training. So this was a trial of 1,600 open fractures recruited at 14 hospitals across the US, Canada, and Spain. And basically to be in the trial, you had to have an extremity fracture that was going to require fixation. There were some basic exclusions, like, you need to get to the OR in 72 hours and things like that. But when you do a randomized controlled trial, most of you are probably familiar with, and if you've talked to patients about participating in a randomized trial, you go and you say, hey, we're doing the study, we're going to flip a coin for which treatment you get, right? And that's the most common individual patient randomized design. But you can actually randomize if you want by hospital, for example. We call that a cluster design. So at Rutgers, you're going to use betadine. At shock trauma, we're going to use chlorhexidine, right? And then there's another level, which is a cluster crossover. So at Rutgers, you're going to use betadine, and then halfway through the study, you'll switch over and you'll use the other one. You'll use chlorhexidine, and vice versa. We'll do the same thing at shock. Well, we decided to take it one step further and do what's called a multiple period cluster randomized crossover trial. So this stuff had never been done in orthopedics, but basically we just alternate back and forth. So we do 2 months of one, 2 months of the other, just go back and forth. And so, visually, that's sort of what this looks like. We find the cluster, which would be the orthopedic practice. We randomize them for which one they're going to start with. In this diagram, they're going to start with betadine. They do a little run in, then they go betadine for 2 months, then they switch over to chlorhexidine, betadine, chlorhexidine, just go back and forth. And the trial ran roughly for about 2 years at each hospital. And the reason we did that is that, cluster designs are kind of nice. You know exactly what you're doing, right? You don't have to run up to the patient, get consent, run down, tell the OR, oh, this time we're going to use betadine, or this time we're going to use chlorhexidine. So it has a lot of simplification. But if the patients at Rutgers and the patients at shock trauma have some other inherent differences, like the baseline risk of infections different between our hospitals, you would potentially attribute that to the intervention and not understand that that's related to the hospital. And so by having you flip over or cross over, that allows your hospital to act as a control. But if you do this for 2 years and you go 1 year of chlorhexidine and then 1 year of betadine, and in that second year, you do something else, like you start putting vancomycin powder in the wounds or something like that, maybe that other intervention is the reason why betadine looks better. So by switching back and forth every 2 months, it really helps to balance out any potential variations, other practice changes, et cetera, that may occur. But this really can only be done in interventions like that, where you can kind of switch out the intervention, right? You can't do this in some sort of learned behavior or a bigger practice change, but it worked out really well for us. So when you look at the actual study and how it played out, 75% of the patients had lower extremity fractures. You can see that we had 40% type 3As and another 6% of 3Bs, 3Cs. So a lot of high energy mechanisms. These aren't just poke hole open fractures. But when you looked at the results, many of you may say, no surprise here, right? So if you look at the very first line, 7% infection rate in both groups. This is CDC definition, so that's infection within 90 days. If you go to the next line, you'll see that if you follow these patients for a year, it almost doubles, so 13% infection rate. But if you look at the p-values, no differences. If you look at the risk differences, you can see that they're very, very small. So, and they cross 1. So no difference in surgical site infection, no difference in unplanned reoperations. And you can see again, that unplanned fracture related reoperations up to 16%. These are problems. Open fractures are still problems that we haven't solved. And perhaps the type and choice of antisepsis isn't going to solve that. But I think it's also reassuring for a lot of environments, certainly in low resource environments, they may not be able to actually procure both or store both. Even during COVID, we certainly had some supply chain issues and struggles at times to have all those antiseptic products we want on there. I also mentioned ChlorPrep versus DuraPrep. So this doesn't answer the question about alcohol-based solutions, but that answer is coming in the next 2 weeks. So we finished another 8,000 patients looking at ChlorPrep and DuraPrep. And so those results will be out next year. The other thing that's important about this slide is the two people standing next, or sitting, I should say, next there. That's Jeff Wells and Deb Marvel. They're 2 patients, and these patients were heavily involved in the study design and management of the trial. You might say, well, how do they have any expertise in running large trials? And the answer is they don't. But stakeholder and patient engagement has sort of become a really big thing in research now. And we know from a stakeholder engagement thing, if you're talking about clinicians, that's obviously important. You got to make sure that the study mirrors what you're doing in practice and the information you're going to want to know as a practitioner. But for patients to have this sort of shared governance perspective where you are involving them in all aspects, it was unique for me. It certainly improved the language of consent when we're trying to get patients in the study. So no longer do I go to patients and say, hey, I'm doing a research study. We'd like you to participate. We're going to follow you at these intervals, sign here. The language has completely changed. Now I say things like, we're really concerned about you developing an infection. We're part of a multi-center initiative where we're looking at 2 interventions that are used commonly. And what we want to be able to do is check in with you over a year, make sure you're doing okay. And that has completely changed the consent process. And that was led by our patients. And it was just kind of interesting, very subtle differences, but they explained it in plain language, which is we don't want to be guinea pigs, right? Like the word research can sometimes scare us, and we don't want to be guinea pigs. And I think I was also a little skeptical to include the perspective of just a few patients. How do I know these 3 patients represent all patients, right? And on top of that, skin prep patients aren't even involved in that decision. So like, it just seemed a little weird, but I think the rationale for patient engagement is actually quite strong. There's numerous areas when you're designing a study that requires estimation or uncertainty that you as a researcher just kind of make up. You say, this is probably the best decision, we're going to do it. And I think in those situations where there's uncertainty, it's okay and probably a good idea to involve patients in making some of those decisions. And like I said, I think some of it has to do with the timing of consent, follow-up intervals, the relative importance of different outcomes, and I'll talk about that. So you can see my patient partners again at a large trial investigator meeting. Patient engagement also is a huge part of this trial. So the Prevent Clot trial was published in the New England Journal in January. This was led by my partner, Bob O'Toole and Metric. And hopefully this clinical question also sort of really resonates with you. So for all orthopedic fracture patients, when they're in hospital and even post-op, what should you do for their DVT prophylaxis, right? So at our hospital, the standard is low molecular weight heparin for everybody. But there's certainly a lot of support to use aspirin. Arthroplasty has really switched over to aspirin quite a bit. And so this study compared aspirin 81 milligrams twice a day versus enoxaparin 30 milligrams twice a day. And it didn't change the duration or the indication. So it's basically, if you think they need prophylaxis, which agent should you give them? And it should be pretty apparent that low molecular weight heparin is certainly more costly to administer, more costly to buy. Patients don't love being stabbed with a needle, right? And our hospital at one point, I think, was spending 20 or 30% of the hospital pharmacy budget on low molecular weight heparin. So a huge cost. And so that sets up this question that basically says, as long as aspirin is as good, or even maybe a slightly worse, probably patients would like it, hospitals would like it, would probably, make things a lot easier. But what is that sort of slightly worse, or what we call a non-inferiority margin? Like, what is acceptable for that? And also, what is the most important outcome? Should it be DVT? Should it be death? Should it be something else, bleeding complications? So to figure all that out, again, I think you should ask patients. And so discrete choice experiments are a way to ask patients these things. And so basically you're asked to indicate your preferred choice for 2 hypothetical scenarios, or in this case, 2 hypothetical medications, right? So you can see on the left, there's a whole bunch of attributes, if you will, about it. Like, so you're going to take the medication daily, and what type is it? So, oral versus needle. What will it cost you? $100 versus $50. What are the chances that you have one of these complications? And so you, as a patient, you sort of put all that together and you pick one. Now we do this about 15 to 20 times, and we just keep alternating different levels of those attributes, right? So you may have one that's super obvious. Who wants a pill that costs more, that's administered 4 times a day, or sorry, an injection that costs more that's administered 4 times a day versus a pill that's once a day and cheaper, right? Like, there'll be some anchors that are very, very obvious, but as you start to blur the lines on the different attributes, you can actually really figure out what's important to them. And this work actually, Dan McFadden and James Heckman won the Nobel Prize for economics. So it's pretty robust. And at the end of the day, you might say, okay, so you figured out that patients don't want to die. Yeah, that's pretty obvious. But it actually told us how much they don't want to die and how they value the other outcomes that can be looked at. So this trial was led by O'Toole, Deb Stein, a trauma surgeon, and Renan Castillo at the Metric Data Center. 21 centers, 12,000 patients. So a huge, huge study. And we used that discrete choice experiment to inform the trial's sample size. So basically, we detected or determined a 0.75% non-inferiority margin. So that basically means patients in the aspirin group could die at an increased rate of 0.75%. So very, very small, but there was a threshold that we had set. And we'd still conclude that aspirin was a good idea. And so that led to a sample size of 12,200 patients. As I mentioned, you needed to sort of be indicated for VTE prophylaxis. You had to have an operative extremity fracture or a pelvis fracture. And then there were a few other exclusion criteria. Primary outcome was 90-day mortality. And then we had some secondary outcomes related to PE and some safety outcomes. When you look at what our patient population looked like, 21% had both upper and lower extremity fractures. Again, 2/3 were mainly lower extremity fractures, but a reasonable trauma population, median age of 44 years, ISS of 9, but also 15% had ISS greater than 15. And when you look at the results, no difference. Not only no difference, but it certainly met the threshold for non-inferiority. So you can see they're almost the exact same mortality rate, very, very low, less than 1%. And when you start to look at what that looks like for a couple other outcomes, so if we look at the top left, right, so you have death being analyzed by intention to treat or per protocol, and you can see you have a very narrow threshold there. It doesn't come close to that non-inferiority margin that we talked about. So you conclude that aspirin is non-inferior, a good idea to use. If you look at PE, you see no PE related death, you see no difference in PE, but you actually do see a difference in DVT. Right? And that actually favors low molecular weight heparin. I think that makes sense as to why low molecular weight heparin obviously also became the standard, right? Because they kept studying DVT. And so as you start coming down bottom left, well, what kind of DVTs? No difference in proximal DVTs, a difference in distal DVTs. So distal DVTs is driving the difference in DVTs favoring low molecular weight heparin. And then no problems with the other safety concerns. So we know aspirin is non-inferior for mortality, but low molecular weight heparin does have fewer DVTs. And these fewer DVTs are in the distal DVTs, and it's a 0.6% difference, right? And I think a lot of people will argue that distal DVTs shouldn't be treated, they don't matter. But that decision now, I think, really sets yourself up for shared decision making. We know that the choice doesn't affect mortality. But if you want to have that patient discussion, you can have that discussion with really good data about whether you want the injections and the cost and the increase to prevent a small increased risk of distal DVT. Did you have a question? No, okay. So, I mentioned that shared decision making. So I want to show one more example here, right? Which the challenge with that shared decision making, right? I just presented that data, right? And now you have to interpret that. You have to go to the patient. You have to try and explain either statistical significance, clinical significance, maybe probabilities or magnitudes. And then there's also this whole other thing about frequentist and Bayesian statistics. And ultimately, all of that can be challenging for us as clinicians when really you're trying to answer a question like this. Would this patient benefit from surgery? So this is what we've called the gray zone LC1 pelvis. You can see a little buckle on the CT. It is a complete fracture, little buckle in the back of the sacrum, a little ramus fracture there. And so when you're trying to figure this out, this was a trial that we ran at Shock and Indiana. And so we were trying to figure out, just for those patients alone, would they benefit from a pain perspective? Because there was all sorts of controversy. Yeah, this will heal just fine. But if you fix them, they get up, they feel better, and they start moving around. And just as an aside, do you guys tend to fix those fractures? Sometimes, right? Yeah. Right. So you want to know what that indication is. And so we enrolled these patients that had a complete sacral fracture, but less than 1 centimeter or less than 10 millimeters of displacement in the back. How you fixed them was up to the surgeon. Both groups had some protected weight bearing for 6 weeks. And then our primary outcome was pain and function at 3 months. And we used the typical ortho trial design. This was very early in my tenure at Shock. And so we had a pain outcome, VAS pain, 10 points, Majid 100-point function. And if you do the typical orthopedic trial thing to detect a 2-point difference with 80% power, blah, 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 it's 80 to 120 patients every time. And I can show you the math behind that, but all of our trials are 80 to 120 patients and they're adequately powered. And that's fine. But that assumes, that the minimum clinically important difference is 2 points, right? And you can debate that. But should that 2-point difference that you're going to change your practice change based on the magnitude of the surgery. I mean, from my perspective, putting in a couple SI screws or PERC, Ramus screw or whatever, is not actually a big surgery. And to have a little bit of benefit from pain, maybe it's worth it. Maybe I don't need to see a 2-point difference. But that's not actually how we set up most of our research, right? And then what are you going to do? Like, how are you going to know when to change your practice? Is it just as long as the p-value is less than 0.05? Or does it have to be more than that 2 points like we just talked about? So, and if we start on the left, like, what do you do when it's 2 points, but the p-value is 0.06, right? And then what does that even 0.06 mean? And so if I take you through a real quick refresher on p-values, which is always painful for everybody, including myself, right? So the p-value assumption is that there's no difference, right? Remember, that's why we always say the null hypothesis, right? So you actually assume that there is truly no difference. And so when you get that p equals 0.06, it's not a 6% probability that there's a 2-point difference. It's a 6% probability that you observed this 2-point difference when the truth is actually there is no difference, right? That's sort of weird. Like, I never think that way, right? And I'm not going to be able to explain that to my patient either, right? That's not how we think, and that's not really the information we need. So there's this whole other thing called Bayesian statistics, and this is Reverend Bayes, who designed this, like, I think in the 1600s to help him gamble. And really what it does is it takes the hypothesis and figures out the probability based on what you've observed, right? So the first example is, what is the probability of the data observed given that the null hypothesis is true, right? That's the frequentist, the p-value thing that we're familiar with. He adopts the second one, which is basically, what is the probability that this difference exists now that I've seen the data out there from my trial, right? And that's really what we think about. And on top of that, sometimes you want to know what the probability of something different, like a bigger magnitude of effect, because that may change your surgical decision-making. I'll explain that over the next few slides, right? So here were the results from that pelvis trial, right? So operative fixation had a 1.1 point improved pain compared to non-operative management, right? And so it's pretty standard sort of visual thing that you might be expected, or that you may expect. And you can see it's significant. But I told you that most people want a 2-point difference. And if you're skeptical and you don't want to start changing your practice off a 1-point pain difference, maybe you'd say, you know what, I'll change my practice if it's 1.5% or 1.5 points improved. P-value testing does not help you with that at all. It doesn't tell you that. Remember, it's just, what is the probability of this being real what is the probability of there being no difference, right? So Bayesian statistics does tell you that. And so I'll walk you through this table on the left, right? So the MCID, this is what you want to see, the clinically important difference. So if all you want to see is any difference, that they're just a little bit better, the probability of that happening is 99%. If you're happy with just a 0.5-point difference, probability of observing that is 93%. As you get to 1 point, it's 56. If you want that 2-point benefit, there's only a 1% probability that that exists. So this gives you, as the clinician, the ability to look at all the data and decide what is the threshold. Maybe the patient's a little more sick, and so I would only do this if I was going to get a huge magnitude of benefit. Or maybe the patient's really, really healthy, they're uncomfortable, and you want to try and do something, and you say, you know what, it's a safe surgery, it's minimal OR time, I'm willing to take on the surgery, even if it's only a 0.5-point difference. So that is a huge benefit to Bayesian statistics that we didn't really have available to us. And it's a similar thing here for the Majid function. The operative fixation improved the Majid by 8%. And I have a similar table here. If you want a 10% increase, you have a 25% probability of doing it. So again, you can see the gradation of different benefits. And so, as I mentioned, for Bayesian statistics, really the benefit is it reports in probabilities, and that's typically how we think, right? It has a whole bunch of other benefits for challenging populations and more efficient study designs, and it's now mainstream. New England has it included in their most recent statistics statement, and all the COVID drug trials use Bayesian statistics, all of them. But when you submit this to the orthopedic journals, you still get, the editor-in-chief basically telling you word for word that he's skeptical of new techniques and he thinks we're trying to do some sort of statistical trickery, right? So I think within our own field, we need to continue to evolve because the other research fields are. And I think that that's sort of where I want to switch gears a little bit, right? When you start looking at what future trials are going to look like. I think the status quo for orthopedic trials is changing, right? And the next generation of clinical researchers and research are going to continue to use more complex study designs that will hopefully be more efficient. And ultimately, any good clinical trial or question needs these things, right? It needs an important clinical question. It needs to be implemented sort of the way we implement them in the real world. That still has to be rigorous, right? And somebody at the end of the day needs to interpret that data and disseminate it to the surgeons that are going to be using that information. And really, in my opinion, the surgeon trialist is actually the only one that can master all those, right? A PhD cannot fully understand the nuances of all the clinical developments, right? And so if this is the case, you know, how do we breed more surgeon trialists perhaps, right? So we know that, like I said, the trials are becoming more common. There's a lot of trial networks out there that make it easier as a new investigator for you to potentially launch a trial in one of these networks. But what skills do you need? How do we identify you and mentor you? And what resources do you need? And this is really the problem that we have right now. So less than 5% of orthopedic surgeons have received NIH funding. And that number actually includes all their training grants, right? So you take a research gap year and the lab has a T32 or something like that, and you get on that, that counts. That counts as part of the 5%. When you look at the Blue Ridge rankings and the NIH funded researchers, they're essentially all non-clinician PhDs. The top 25 have 2 surgeons. One of them does basic science research. I'm the only clinical researcher, and I'm just barely in there at number 23. And I think that really those challenges are the fact that the K award, this is like the NIH training award pathway, requires 50% of your effort in your first 5 years of practice. So you're trying to learn how to be a surgeon, and right off the bat, you have to give at least 50% of your time to the research. Your surgeon salary, fortunately, far exceeds the NIH cap that they're willing to pay for you. So now your department chair has this weird dilemma of saying, I have to now subsidize your salary, and they either don't have the ability, the flexibility to move funds, or they don't want to. And frankly, research as a part-time hobby for us, it just doesn't compete at the level when people are doing research at a full-time basis. And hopefully that makes sense. And here's some data to prove it, right? So if you look at the top journals, JAMA, Lancet, New England, and you look at the burden of disease, these are NIAMS, this is sort of our NIH Institute for Musculoskeletal stuff. So fractures and low back pain on the left, so orthopedic problems, and on the right, the number of publications by topic in these high impact journals, right? So, you know, clinically meaningful research, of course, is going to improve care, right? And you need rigorous research and expertise to do it. And we're just not there. And the reason we're not there, I think, is because of lack of mentorship, right? Our grants don't do well at the NIH, typically because they haven't been written or co-written or mentored by people who have succeeded, right? And as I said, I was fortunate to work with Mo Bandari, but he also worked with PJ Devereaux, who's doing 50,000 patient cardiology trials all the time. Lahana Tabani, who's a statistician, he's done over 100 clinical trials. And Gordon Guyot, who coined the term evidence-based medicine, right? So those were his mentors, right? So that's a pretty sweet pedigree that Mo had, and a lot of support as he was learning how to do this. And so it's, you know, something that I think about as well, right? Like, how can I change that? And so I'm very fortunate. I have what's called a K24 award. So it doesn't require 50% of my time. It's mid-career already. So I sort of had to like bypass the early career and come in at the mid-career. And this gives me some protected time to mentor and support other people. The shock trauma, you know, sort of fellowship alumni network, a lot of our grads recently go to academic positions. So about 80% of them take academic jobs now. And so that has helped me create a bit of a trials network where my past fellows are involved in large clinical trials. And then I've sort of developed this triangle of mentorship and access that I'll explain in a second. And lastly, we've just recently set up this Center for Orthopedic Injury Research Innovation. And so what CORI is it's a service center, and I didn't even know what the hell that was. But the University of Maryland has these things called service centers. And it's basically where we can offer a service to people. And, you know, we like to think that CORI is where investigators and evidence can grow. We're not a method center. We're not Metric. We're not McMaster. But Nathan O'Hara and Sheila Sprague, who are my 2 closest collaborators, the 3 of us really are interested in this, which is aim one, to expand research expertise. We just want to talk to as many people and try and train as many people to think about research and to be a good user of evidence-based medicine. We want to develop new ideas and we want to implement rigorous methods. And so as a new investigator comes up with ideas that they think may be fundable, help them grow that, get the pilot data, help them get the grant, and then have them go to a method center like Metric or Master to actually run the trial. And so the way I do that is through this sort of triangle, as I mentioned, of access and mentorship. So at the bottom, I have medical students or undergrad students, research coordinators, et cetera. And I want to try and reach as many students as I can, but sort of in a once or a twice in the year type of perspective. So they don't get a lot of my time, but I want to at least try and inspire them a little bit. And we do that with the AO Peer course. Just like a lot of other AO courses, there's actually an AO research course. And it's a 2-day course. And we use that to try and recruit students into orthopedics, particularly from a diversity inclusion perspective. Orthopedics has struggled there. And one of the reasons is I think we don't latch on to students early enough in their career. We then train more people to teach the course. And then, like as I said, we have opportunities for novel data analyses, working groups, consultations. And then for a very few amount of early career trialists, I have a ton of experiential mentorship that takes a lot of time. And these are two of sort of the 3 people that I'm heavily mentoring right now, Joe Patterson at USC and Lucas Marchand at Utah. And what I've done is I've basically created multi-PI models for all of our trials. So now I don't want to be leading any trials by myself. So I bring in new investigators and I put them right into the trial, and they're running all the aspects of the trial. They get the salary support. They're going to be the primary author. They're going to be the one presenting this on the podium. And so Lucas is working on the antibiotic bead pouch versus wound vac trial for severe open tibia fractures. And Joe Patterson is going to be looking at minimally displaced femoral neck fractures to actually consider arthroplasty instead of percutaneous screw fixation. And as I mentioned, my long-term vision, I think, is to continue to try and make trials more feasible to new investigators. Ultimately, I kind of see everything going open source so that all the stuff that I've taken a decade to develop is just out there and anybody can use it, and you can use it, modify it, and make it available to the next person as well. But ultimately, I want us to be able to help you design trials and then have you run them locally. I can't run every trial. I don't have interest in running every trial, and not everybody needs somebody else to run their trial for them. So I'm hoping that that's the future and the long-term vision. And again, just continuing the cricket analogy that nobody will understand, but I love it nonetheless. World Cup cricket became the new thing. It was one-day cricket. They started having colored uniforms, and really it was the same game with kind of some new rules. And I think that that's where we're at solidly now in research, right? And I'll just give one last example, which is a new method that we're using for a bunch of our new trials, which is something called the win ratio. So rather than just lumping a bunch of outcomes together and pretending they're all the same, which was done in the sprint trial, for our latest hip fracture trial, we're going to include mortality, ambulation, and days away from home. But we get to analyze them in a hierarchy, and each patient is essentially compared to each other, right? So it's like patient 1 versus patient 1 in the other group. Are they both alive? Okay, that's a tie. So we go to ambulation. Do they both have the same ambulation ability? Okay, we're still tying. Okay, one of them got home way sooner than the other, perhaps with arthroplasty. That's a win for the arthroplasty group. And you just keep doing that over and over again. You get a ton of pairwise comparisons. It adds a lot of statistical power, and I think it represents the hierarchy of importance of the outcomes to the patients. And so I think we're really in this new investigator, new trial, new methods approach right now. And all 3 of my mentees are actually going to be using this for the next trials. So we've been kind of going for about 35 minutes, and I've basically summarized a decade of work. And it's a decade of work that I'm pretty proud of. But really, I think all it really shows us is that we have increasing rigor and certainty to suggest that we're still not winning. I think our status quo is not acceptable for 3A tibias, for hip fractures, perhaps for proximal humerus fractures. We still can't figure out if we should be operating on them, and the NIH funding situation. So with all that said, I have just a few more slides. And really, I bring up the third horizon. The third horizon is potentially a time for a paradigm shift, perhaps both new game and new rules. And what does that even look like? This is now like Indian cricket, which is apparently hugely successful, large contracts, fast, bright uniforms, just totally different. And if we're in a new game, new rules, perhaps new questions, are we asking some of the wrong questions in orthopedics? Oftentimes we ignore the larger perspective. This is a map of Baltimore. Those are all the abandoned houses in Baltimore. And I think it's really important that we consider the ecosystem that these fractures occur in, and where these patients have to return. As I mentioned, my ankle fracture disaster at the beginning. Hopefully many of you have seen this this pie chart. It's from the government, and this is sort of the new social determinants of health model that they want for healthy people 2030. And you can see all of these things, I think, definitely affect your health, right? And you're seeing a ton of papers like this, like ADI associated with mortality after surgery, race associated with suboptimal fracture-related infection. Personally, I'm kind of tired of seeing these. Like, I get it, and I think they're important to note, but like, how am I supposed to fix poverty or gun violence or structural racism to improve my orthopedic outcomes, right? It just seems a little bit beyond what I can do. And I think obviously there's no simple answer. Dan gave a nice introduction. I'm the levels of evidence editor for JOT, have been for 10 years. So every single paper that comes out of JOT, I review and assign the levels of evidence. I've also been a grant reviewer for all of these agencies. And despite all that, I think we're capable of asking better questions than just 3 screws versus 1 screw, or should we lateral in the supine, or should we nail in the lateral supine position, or what is the association between wound contamination and infection? For the record, these are all my studies. I'm no better than anybody else here, right? Like, I'm doing the exact same research, but I think we are capable of more now. And as I mentioned, wicked problems, I think we've mastered the methods to answer simple problems. Wicked problems, by definition can't be answered. And I think we need to start developing at least some strategies to try and address them. I don't know what those strategies are yet, to be honest. When we look at some interagency solutions, here's a picture of me actually going on the helicopter to that scene that I showed you earlier. And these helicopters are Maryland State Troopers. And so they get money both for policing as well as for EMS and patient transport. So right off the bat, here's a long-standing sort of thinking out of the box merging of funding agencies. We're hearing more about social prescribing, where as a doctor, you can prescribe food to somebody in some states, right? You can prescribe housing. So are there opportunities to involve the DEA or HUD or Social Security Administration, IRS, to try and answer some of our questions in a little bit more novel method? And I think the expertise needed to move into that area, in Horizon 1 that I first started off with, orthopedics realized, hey, we need some statisticians. We just need to better understand data. Horizon 2, sort of newer game is where we're at now for sure. We've got the epidemiologists and the trialists involved. But for us to get to this third horizon, I think we really need to expand who else we're getting involved. And ultimately, like I said, Mo called us to think big. I think we're achieving that. But really, I think my vision is for us to collaborate more, to think even broader. And for clinicians, I think we have to broaden what we're considering an intervention, whether it be social prescribing or something. As researchers, I think we have to broaden those collaborations. For chairs and institutional leaders, I think we have to find more ways to support those clinician scientists. And as a trainee, I think it's an exciting time. I think it's a time that you can pave a new way. I think you can ask really random questions, new questions, find new techniques, and even new job models. I think our field of orthopedics is becoming a little bit more open to some newer job models. And so hopefully with all of that, groups like the AO and things like that will continue to create areas where we can foster collaboration, ideas, growth of our next generation so we can answer some. Thank you for your attention. Any questions? Go ahead. Oh. Yeah. So the question was, of the three large trials, have we changed our practice from the data? And so the short answer is absolutely yes. So on the betadine chlorhexidine, we tended to use betadine for open fractures. So we've kind of gone back to that. Chlorhexidine, aqueous chlorhexidine is kind of annoying to use. Hibiclens is kind of annoying to use as a prep. So we've kind of stayed with betadine, but it gave us the data to support that. And I'm really, really curious to see on the alcohol-based ones, because particularly type 1s and 2s, it's kind of hard not to put the alcohol in the wound, but also who cares? It's not a big wound. And even for the type 3s, we were using ChlorPrep and DuraPrep on those. So I'm really excited to see what happens there. But yeah, that's how we've used that. For the aspirin, low molecular weight heparin, if it's our choice on the orthopedic service, we always use aspirin now. The trauma service is still trying to decide. We actually had a town hall about what we should implement, and they agree that they should implement aspirin for the straightforward patients, basically, but they're still struggling because in the trauma VTE world, they are now going to, I think, measuring factor 10A or something, right? They're now trying to quantify what the level is and then doing essentially dose response enoxaparin giving, right? So like, although it was 30 milligrams BID, and then they're like, oh, maybe we should do 40 for larger patients. They now want to start measuring this blood level, which is very expensive. And then they want to start giving even more Lovenox to some of these patients that are apparently being underdosed. So I think we're going to save all the money on the easy patients and then probably double the budget on these more expensive patients. So we're still working on that. And all the subgroup analyses that will start coming out from that trial show that even high-risk patients, the effect's exactly the same. So, the trauma team, I think, will still argue that, oh, we don't know about high risk, but we actually do, and there is no difference. Aspirin's just as safe. Sorry. Oh, hey, what's up? Good to see you. Yeah. Yeah. Thanks. Yeah. Yeah, I heard. Awesome. Yep. Yeah, so there definitely will be a cost analysis. The US healthcare system, because I grew up in Canada, is very unique. And so at first glance, obviously low molecular weight heparin is way more costly than aspirin. So it's sort of a no-brainer. But then there's some weird things that happen where maybe your hospital is able to actually charge for administering the Lovenox because it's an injectable. And so although maybe you're paying more, you may be recovering some of the money from that. So each hospital system may be a little bit different in that, but in general, yes, there will be a cost analysis, we're almost done it, both from the patient perspective, but also from the hospital perspective as well. But I think it's a no-brainer. It was a third of the hospital budget at Shock. Okay. Yeah. Yeah, so I don't know that we've distilled the data to that level yet, but they were in the study, right? And so, as I mentioned, the trial only determined which prophylaxis you'll get. So all those patients, of course, were on prophylaxis the entire time. So those patients were in that study. So from our perspective, it doesn't change that. And I think, the other interesting thing when we were going through the New England revisions and, going through that peer review process, the editors really wanted us to put a statement in there that says, in low risk orthopedic patients, aspirin is non-inferior. And we argued with them. We said, that's not true. Yes, the mortality is only 1%, but that's just life. We're getting pretty good at medicine and keeping patients alive, right? But these aren't low risk patients, right? These are patients with multiple extremity fractures. And if you use any of the DVT prophylaxis, Caprini scores or whatever, they were all, a lot of them were high risk. So we were able to push back pretty strongly about this low risk, high risk. And then we still ended up doing further subgroup analyses about it. So I think even in high risk patients, if you want to consider those patients high risk multiple debridements, I think it's still safe to do. And then your second question, it may be pharmaceutical driven. I don't think so. I think really the problem is that we're just not good at this. And we're not good at this, not because we're incapable. It's just we have no guidance, right? So how many papers have you written for the internal medicine audience? Like I'm used to writing for orthopedics, right? And so we're not used to writing 2,900 words for the New England. We're not used to being concise. We don't get experts who've published, statistician experts that have published in the New England 100 times. So it's just so hard for us to break into that level that you try once, you fail, forget it, and you never try again, right? I remember Mike McKee. I did my second fellowship with McKee, and I told him I was applying for a large federal grant. He's like, "Oh, I did that in my first year of practice too." I spent 6 months working on it. I got rejected with no comments. I said, "Never again." And McKee's a pretty competent researcher, but I think that just shows our experience, and I think that that's valid. And so if we want to change that, we have to change the paradigm that we work in. There's a question maybe on the chat or something. Oh. All right. Sure. Yeah. 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 So the cluster randomization or randomizing by week or whatever is a very efficient design, as I mentioned. IRBs are always a little weary to make sure that you're not trying to do that to get around consenting patients. But because of all the stuff we talked about, the effectiveness, the fact that they're never involved in this decision, we were able to work that through the consent or through the IRB process. So then consent really just became about allowing us to collect their data, right? Which made it a very easy consent process, and it was supported by the patients, right? So our patient partners, when we were designing the study, what they said is, wait a minute, you want to go to patients who are in acute pain, who have an open ankle fracture, and you want to ask them if they're going to participate in a study for 2 interventions that they never know that they get, that don't really matter. And that's what you want to waste their time with when they're trying to get their family on the phone or prepare for surgery or whatever, right? So it's not actually patient-centered at all, right? So we were able to use that argument as well to say, we're going to approach patients after surgery when they're recovering, when they're in a better mental space, to ask them if we can continue to follow and collect their data. And of course, as you can expect, the consent rate was pretty high. So it was really helpful.
Changing your paradigm.
Yeah. 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 So and you participated in Regain too, didn't you? Yeah. So the Regain trial was great, and I know Mark Newman very well. He's actually involved in this minimally displaced hip fracture trial that we're doing, and I think it takes data. I'll give you another example. So I don't know if you're familiar with the hip attack trial. So this was a trial that basically rushed hip fracture patients to the OR within 6 hours, right? So the idea that we know delayed hip fracture surgery is associated with mortality and all this kind of stuff. So 3,000 patients, PJ Devereaux, actually, this same guy right here, slide, maybe. This guy on the bottom left, he's a cardiologist, and he designed this trial. 3,000 patients, half the patients randomized to hip fracture surgery within 6 hours versus your standard, which is typically 24 hours, to see if it would reduce mortality. And it didn't. Okay, thank God we don't have to get up in the middle of the night to do hip fractures, right? But it actually did show less delirium, earlier mobilization, and of course, most importantly, it was safe. But the thing that was most interesting of that was there's 350 patients in that trial that were also randomized that had a pre-op troponin elevation. So they're sitting in the ER, and you probably have seen this, right? Their trope's 0.1. What do? All cardiology. What do? They come tomorrow, right? And then by the time you get them on the list, at least at shock, I'll tell you what happens at shock. Our median time to OR for that patient is 46 hours, median, right? And what changed for them? Like 3 of the 200 went to the cath lab, right? So basically nothing changed for the majority of patients. And we wait and we delay their surgery. In that hip attack subgroup of the 350 patients, what do you think happened with the mortality? So patients that have elevated troponin, their mortality is 25% in hip attack. At shock trauma, it's 27%. 90-day mortality, 25%. What do you think happened to the patients that were rushed to the OR? Went down 10%, 25% to 10% mortality rate. That's huge, right? And so not only did it show that it was safe, it showed that it actually may have a huge benefit. And I think that's a big paradigm shift, the idea that, hey, we have somebody who's, we're kind of watching, we're not sure if they're safe to go to the OR. And by watching them, we're just, prolonging their inflammatory response, and maybe that they're not, that they have to go to the OR faster. So we're doing the hip attack 2 trial, which is now only going to enroll patients that have elevated troponin. 1,100 patients, we're already 150 patients in. And that, I think, is going to be another example where I think it's going to show a big benefit, and that'll be a huge paradigm shift, right? Because most of these patients are asymptomatic. 20% of your hip fracture patients are going to have an elevated troponin in the emergency department if you check. And I don't think we should be delaying them. I think we should be speeding it up. Yeah. I mean, if you think practically about that problem, right? So the troponin's 0.1, so you call medicine or you call cardiology, and you call them and you say the troponin's 0.1, they have no EKG changes, and they're asymptomatic. That's not really a cardiology consult, right? You're just asking them to help cover your ass medically or medical legally, right? So they have no interest in coming, so they come when they eventually come, right? And so meanwhile, the patient's just not doing well, essentially.
2 questions. The first is, how did you go about picking 3 patients out of thousands to help design that first trial? And what kind of bias do you think is included in that? And then the second one is for the DVT study. Is there a set protocol for searching for DVTs in all these patients? Our trauma service here gets a duplex every week. Is it just symptomatic DVTs?
Yeah. So I'll start with that question real quick. So the protocol didn't have any DVT detection parts in the protocol. So it was whatever standard care you wanted to do. And we monitored to make sure there wasn't differential testing, right? So you're like, oh, the patient's on aspirin. I don't really trust aspirin, so I'm going to get duplexes every 2 days or something like that. So we monitored for that. There was no evidence that was occurring, but it was purely whatever your standard of care was. So hopefully just ordering it for symptomatic. The second question, I think, is a great question, right? So if you recall, I have 3 middle-aged or older-aged white people from Maryland representing the whole country. And that's what I had, right? And the challenge, that's why I was skeptical too, right? And the challenge is I think what we face, right? So I had a great rural, African-American, 22-year-old male patient that was involved for the first week. And he just started like, nah, I've lost interest, right? He's like, it's 2 hours for me to get here. You know, you've operated on me 100 times already with my infected open femur. I want to move on with my life. And that was that, right? And I think that in many senses, that's a learning experience for me. Like, so we have better ways to engage patients now. And, you know, shock traumas in West Baltimore. And so we kind of latch onto West Baltimore community. And so we have a lot better engagement in church groups and other ways to get the inner city urban population involved in our research now. You know, that was already 7 years ago when I essentially started that. Yeah. No, so again, if they were indicated for a outpatient prophylaxis, you kept the same thing, and it wasn't supposed to change whether they were indicated for outpatient, right? So if you're a 30-day person, you're supposed to give them 30 days of aspirin or low molecular weight heparin. Practically, what did happen was more patients continued their medication at home on aspirin than low molecular weight heparin, but not by a huge amount. But there was some pragmatic, you know, happening of that, I think, right, with insurance or people just not wanting to take the injections, whatever. Yeah, I mean, I think the way I interpret the results is, I think they were very pragmatic, and so I'm going to continue to apply the results the way the trial went. Meaning, if I think they should have 30 days of prophylaxis because they were an acetabulum fracture that's not going to mobilize for 6 weeks, et cetera, then yeah, I'll give them 30 days of aspirin. If I think they were an ankle fracture that probably doesn't even need prophylaxis, then it's just in hospital and I won't even give them anything. Just because that's how the trial ran, and that's sort of the safety of it. Sure. Yeah. Yeah, I think obviously there's powers in numbers and you know, big data and things like that it's going to help us for sure. What, you know, some of the challenges we have, I think, in the US, of course, are the coding errors, right? The coding for billing purposes. And then of course the payer issues, multiple different payers and stuff that I think has limited our ability to follow good cohorts. Like in Canada, you get one number for your province, and as long as you don't move provinces, that we can follow you forever. And then of course you go to the Scandinavian countries, it's even better, right? So I think in the US, the registries will probably work best for arthroplasty and for older patients. You know, the ACL registries and stuff also I tend to work pretty well. But I think the big difference with ACL or arthroplasty is they're very specific populations, they're very specific questions. And the flip side on registries is I'm not a big fan of them if you don't know what your question is in advance, right? There's so many things that you could put in a registry. And so just randomly having a registry for a whole bunch of different problems is unlikely to give you enough data, and people aren't going to be motivated to contribute. And then you got to figure out how you're going to fund it or why they're going to contribute. And I think it'll fall apart quickly for a lot of stuff in fracture care, but in other areas of orthopedics, I think it's right. Yeah, I think there's all sorts of small things that can be done early, but it's the usual problem. It's like, well, that doesn't come out of my budget, or that's not my responsibility. But even simple things like transportation to physical therapy and things like that, right? Where you can't get to therapy because you can't get on the bus. The bus doesn't come by, the bus isn't accessible, whatever it may be. And I think even little things like that could be probably tackled without as much challenge as the IV drug using homeless problem. But we gotta get our hands around that a bit too, to some degree. Well, thank you very much, everybody. I appreciate it.